This is a summary of the Medicare MSSP Accountable Care Organization 33 quality measures as presented by the Alexian Brothers Accountable Care Organization. The ACO quality point scoring system as developed by CMS is based on placing the metrics into 4 domains: the patient caregiver experience, care coordination, patient safety, preventive health, and the at-risk population. The 33 ACO metrics are delegated to one of these domains, which are weighted equally in creating the final score. Points earned are based on the percentile performance achieved in each metric or composite measure and range from the 90th percentile down to the 30th percentile. Achieving a score less than the 30th percentile would garner no points for that particular measure or composite. We must achieve at least a minimum attainment on 70% of the measures in each domain to qualify for shared savings. The first domain includes 7 measures that reflect patient experience with ACO providers or staff and the hospital. Surveys are distributed to beneficiaries at the beginning of the year following a measurement period. For the initial measurement year, CMS distributes these surveys directly to the beneficiaries. After the first measurement year, the ACO delegates a vendor to distribute the surveys. We are measured on getting timely care, appointments and information, how well providers communicate, patient rating of providers, access to specialists, health promotion and education, shared decision-making, and health status, functional status. Obviously, we want our providers to offer the highest quality care across the continuum with an emphasis on service availability to the patient. Some of the methods the ACO will use to help with this include outreach from nurses, social workers, health coaches, and other ancillary staff as necessary, communication with providers regarding care gaps, and other area services and innovations that arise. ACO 8, Risk Standardized All-Condition Readmission. This is the risk-adjusted percentage of ACO assigned beneficiaries age 65 and older who were hospitalized and subsequently readmitted to a hospital within 30 days following discharge from the hospital for the index admission. This measure places the onus on quality care of the inpatient and appropriate follow-up to decrease the risk of readmission. The evaluation of readmissions has been a common trend in recent years. There are several situations which are excluded from the equation because of difficulties capturing full data and/or there is more difficulty in quantifying the quality of care, and these include admissions for patients with medical treatment of cancer, primary psychiatric disease, rehabilitation care or fitting of prostheses, and patients who are discharged against medical advice, as well as planned readmissions such as outpatient surgery. ACO 9, Ambulatory Sensitive Condition Admissions, COPD or asthma. This measure looks at all discharges with a principal diagnosis for COPD or asthma for beneficiaries aged 40 and older, with risk-adjusted comparison of observed discharges to expected discharges for the ACO. The measure is calculated based on claims data. Our ACO population is risk-adjusted as to the potential for admission to give a denominator of expected discharges with a principal diagnosis of COPD or asthma, and the goal is to manage these patients as completely as possible as outpatients. Exclusions to the measure include patients with diagnosed end-stage renal disease and admissions that are transfers from a hospital, skilled nursing facility, or another healthcare facility. ACO 10, Ambulatory Sensitive Condition Admissions, heart failure. This measure looks at all discharges with a principal diagnosis code for heart failure, with a risk-adjusted comparison of observed discharges to expected discharges for beneficiaries 18 and older in our ACO. As with ACO 9, this measure is based on claims data and involves CMS risk-adjusting our heart failure population to determine the expected admissions for heart failure. And the goal is to manage these beneficiaries as completely as possible as outpatients to minimize the actual observed discharges for heart failure. Exclusions to this measure are similar to ACO 9 and include patients with end-stage renal disease and admissions that are transfers from the hospital, skilled nursing facility, or another healthcare facility. ACO 11, the percentage of PCPs who successfully qualify for an EHR program incentive payment. This is the percentage of ACO primary care physicians who successfully qualify for a Medicare or Medicaid electronic health record incentive program payment. So this stresses the importance seen in PCPs using EHR to document for patients. For CMS, the importance is at such a high level that this measure is double weighted compared to the other metrics. The act of capturing data from paper charts is more laborious and much less efficient. The goal is to demonstrate meaningful use of an EHR through improvements in quality, safety, and efficiency of care, improved care coordination, promotion of population health, exchangeable and extractable beneficiary information to complement the care coordination, and promotion of privacy and safety of patient information. Use of a certified EHR is necessary to satisfy this measure. A list of the certified EHRs can be found through the Office of the National Coordinator for Health Information Technology or through the link shown. ACO 12, medication reconciliation. This is the percentage of patients aged 65 and older who are discharged from any inpatient facility, including a hospital, skilled nursing facility, or rehab facility, and seen by the provider providing ongoing care, including the PCP, practicing practitioner, registered nurse, or clinical pharmacist at the office within 30 days following discharge, and who had a reconciliation of the discharge medications with the current medication list in the outpatient medical record. This measure simply asks the provider to demonstrate that the discharge medications have been reviewed and compared to the outpatient medication record, and that the medications are either maintained as per discharge or adjusted at the office visit within 30 days after discharge. ACO 13, falls, screening for future fall risk. This is the percentage of patients aged 65 years and older who were screened for future fall risk at least once within 12 months. Because patients may not volunteer information regarding falls, this measure emphasizes screening for risk and establishing a plan of action for a positive fall screen. The screening for fall risk can include various elements, but at a minimum may include answers to the following two questions. Has the patient had 2 or more falls in the past year, or has the patient fallen at least once with injury in the past year? Documentation of appropriate assessment should be identifiable in the patient chart. A positive fall risk assessment would lead to documentation of a plan of care, though this is not required in the numerator for the metric. The only exclusion to the metric is a medical reason for not screening. For example, a patient is not ambulatory, i.e., wheelchair bound, etc. But this would need to be noted as a patient condition in the chart. Using a code like V46.3 would help establish this. ACO 14, influenza vaccination. This is the percentage of patients 6 months and older seen for a visit between October 1st and March 31st who received an influenza immunization in the office or reported receiving vaccination elsewhere during the influenza season. From a documentation standpoint, one does not need an exact date, but documentation that it was given during the flu season. Although flu season is considered to be October through March, an influenza vaccination administered during August or September of the flu season would satisfy the measure. This covers the earlier stocking of vaccines by pharmacies and offices. Exclusion to the metric include medical, patient, and system reasons, for example, allergy to a component of the vaccine, patient refusal, vaccine supply issues, etc., as long as it is documented in the chart. ACO 15, pneumococcal vaccination. This is the percentage of patients age 65 and older who have ever received a pneumococcal vaccination. Like the influenza immunization measure, an exact date is not mandatory, but documentation that a pneumococcal vaccine was ever given, even prior to 65 years old, would satisfy the measure. The only exclusion is a medical reason. Patient refusal does not satisfy this measure. ACO 16, body mass index screening and follow-up. This is the percentage of patients with a calculated BMI in the past 6 months or during the current visit documented in EMR, and if abnormal, a follow-up plan is documented. This metric has parameters which are age-based. Age 65 and older, a BMI of greater than or equal to 23 and less than 30, age 18 to 64, BMI greater than or equal to 18.5 and less than 25. We need to address both underweight and overweight patients. Per CMS guidance, the key to this metric is the documentation of a plan for weight that falls outside of the parameters. The follow-up can include a future appointment, referral, education, medication, etc. Exclusions to this metric include certain medical or patient reasons that are acceptable to remove them from the denominator, including wheelchair-bound status, a patient in palliative care, pregnancy, a patient who refuses to be weighed, or some other documented reason. ACO 17, tobacco use, screening, and cessation intervention. This is the percentage of patients aged 18 and older who received tobacco screening at least once in the previous 24 months and, if a positive screen, received cessation counseling intervention. This is a straightforward measure. Screen all beneficiaries for tobacco use, including chewing tobacco, and if a positive screen, provide intervention, whether brief counseling or pharmacotherapy, and document this. Tobacco use includes all forms of tobacco.